Hello again, class, and we are now here to talk about stomach disorders, namely gastritis, acute versus chronic, because those can be a precursor to peptic ulcer disease, which we will get to in a later recording. So if you are looking at this image here, just because we're going to reference some of these anatomical points, this area right here is referred to as the cardia, and that represents the opening of the esophagus into the stomach. This upper portion of the stomach is referred to as the fundus. And then here you have the body of the stomach, and then this lower part here is referred to as the antrum. And so that's the distal portion of your stomach that's leading into the duodenum, or the uppermost part of your small intestine. And then here you have what is called the pyloric sphincter, and that regulates the passage of chyme into the duodenum. When we talk about gastritis, basically what we're seeing is a breakdown of the normal mucosal barrier, and that allows hydrochloric acid to then damage the mucosa, and that results in irritation, inflammation, edema, and then erosion of that mucosal layer. So with acute gastritis, what you see is an increase in hydrochloric acid plus a decrease of alkaline mucus production, and that leads to injury of the mucosal lining and more inflammation, and then those erosions that I mentioned. And the most common spot for an acute gastritis to occur is in the antrum of the stomach, or that lower portion of the stomach. And that's in contrast to chronic gastritis, which is an autoimmune attack against the parietal cells. And this actually leads to decreased hydrochloric acid production and a decrease in intrinsic factor, which overall leads to atrophy and inflammation. So the genetic mutations that occur from chronic gastritis may be due to chronic H. pylori infections, and most commonly those mutations occur among women of Northern European descent. And the fundus of the stomach, or that upper portion, is the most common location for chronic gastritis. So again, with chronic, that loss, that atrophy, that loss of parietal cells results in a loss of intrinsic factor, which we need to absorb vitamin B12, and that's necessary for red blood cell maturation. So as we get to our treatments, you'll see that patients with chronic gastritis may require lifelong injections of B12 for that reason. So these images here are just to do a quick overview of our gut lining. So in our initial recording, I said that our GI tract is a series of hollow tubes that go from the oral cavity down to the anus. And you could see here by the image on the left, the lumen is the opening of those tubes. And that lumen is surrounded by your mucosal layer, which then if you come over here, you can see that. And there's 3 different layers. And then beyond that, you have a submucosal layer, you have a muscular layer, and so on. So now looking at the picture on the right, when we discuss gastritis, we're talking about smaller, more shallow erosions that typically affect the epithelial layer, sometimes into that lamina propria layer, but what it does not do is get into the muscular layer. If that happens, then we now have a bigger problem. We have ulcers. So, in general, when we have this inflammation from gastritis, all these different types of cells that you see here can be injured, and that causes a generalized inflammation of the mucosa. And the mucosal layer tends to be thinner in these patients, so they have less protection as that acid starts eroding away and getting deeper and deeper. So what we don't want to happen is we don't want it getting deeper to the point where it then forms an ulceration, because then you have a risk of developing a GI bleed. So, and again, when we're talking about acute gastritis, we're talking about the antrum, or the lower portion of the stomach. So, one of our main causes of acute gastritis is taking NSAIDs. So, just to review that pathway again, there are two types of COX enzymes in your body. You have, or cyclooxygenase. So you have the COX-1 and the COX-2. Both of them make prostaglandins, and prostaglandins are like hormone kind of chemicals that play a role with inflammation and pain and fever. And the effects of those prostaglandins are slightly different from COX-1 to COX-2. So COX-1 enzymes are the only enzyme that makes prostaglandins that can help your blood clot, and also they protect the lining of your stomach and your intestinal tract from acids created during digestion. So COX-2 enzymes make prostaglandins that are mostly involved in inflammation. Alright, so why am I telling you this? Because when we're talking about NSAIDs, you have the more common NSAIDs like your ibuprofen, naproxen. They affect COX-1 and COX-2 enzymes, and aspirin is another big one. And those are referred to when they affect both. They're called non-selective NSAIDs. And then they came out with a newer class of COX-2 inhibitors that precisely target COX-2 enzymes, and they call them selective NSAIDs. Anywho, although COX-1 inhibitors block inflammation, they also block those good effects of that stomach and intestinal lining protection and clotting control, unfortunately. Whereas if you took a COX-2, like a Celebrex, for example, your stomach lining and your intestinal lining and your ability to clot are not severely affected. However, there have been incidents where COX-2 have an increased correlation with cardiac events, so not everybody is a candidate for taking those. So anyway, when we take these NSAIDs that block that, and they block that COX enzyme production, it leads to decreased prostaglandins, and then that's going to lead to increased hydrochloric acid production and also decreased mucus production, because we're losing that protective lining. And to make matters worse, drinking alcohol while taking the COX inhibitors can increase the risk of ulcers. Gastritis can also result from bacteria in the stomach called Helicobacter pylori, or H. pylori. And this is a stomach infection that can lead to the formation of ulcers. So for that one, the pathophysiology is a little bit different. Hopefully you listened to the recording on the different cells of the GI tract that was in your initial lecture, and this is making more sense to you. But the patho for H. pylori infection is once it leads to increased gastrin production, which then leads to increased hydrochloric acid, and then an increase in urease, or rather, I should say the second mechanism that causes the gastritis is because of the infection. There's an increase in urease, which leads to an increase in ammonia production, and that environment actually helps the H. pylori to survive. Okay, and then in turn, the bacteria causes it releases toxins that damages the cells in the stomach, and that can lead to inflammation and erosions. So those are two of the most common. I put on there a couple other causes. That's not going to be our focus for the purpose of our lecture and our test. But these, just to put these out here, if you wind up working maybe in an ICU or in a burn unit, stress and gastric erosions can occur after a physical trauma, after burns, shock, hemorrhage, sepsis, and then based on those pathways, the stomach starts to fail us. So the curlings, ulcers, essentially you have burns, patient can become septic also from the burns. They also become hypovolemic, and we have those fluid shifts. That contributes to gastric ischemia, which then can lead to lesions and erosions in the stomach. And then with your Cushing's ulcers, that's usually caused by a traumatic brain injury or something that's going to increase ICP. And then that leads to the vagus nerve being overstimulated, which leads to increased acetylcholine production, which leads to increased hydrochloric acid, and then takes us back to that process of inflammation and erosions. So those are up there for you to think about, but our main focus is going to be on the NSAIDs and the H. pylori. This next slide goes over some of the symptoms of gastritis. So typically, because of the pathophysiology, these patients often present with epigastric pain, which can radiate around to the back. One differentiating factor between gastritis versus ulcers is that the pain with gastritis typically is not affected by food making it worse or better, which helps you distinguish between different types of ulcers, which we'll get to in a minute. Now, I say that, now there are risk factors such as eating spicy foods, large meals, and alcohol that can be triggers. However, what I mean by that is, if I don't eat, does it make it worse? Or if I do eat, does it make it worse? No, it's just the things that I ate that have caused this process. So we already said H. pylori is a risk factor. Smoking is another risk factor. Another sign that's not on there is feeling full. If a patient is belching a lot, that can indicate that there's a lot of inflammation, or sometimes with H. pylori, that bacteria in the stomach can make people burp a lot. When there is alcohol abuse, there's more commonly a correlation with gastric bleeding. So when we're assessing, in addition to recognizing the cues you see up there, you also need to look for signs of bleeding or hemorrhage in these patients, such as hypotension and tachycardia. And with your chronic gastritis patients, you want to assess for vitamin B12 deficiency, and sometimes they also complain of having a sour taste in their mouth, which may help you to differentiate. When we are looking to diagnose gastritis, there's several ways of testing for H. pylori. Um, One is through a biopsy, and there's actually two different ways via a biopsy to do that. The first one is the urease test. And so when the patient's having a biopsy, they get a tissue sample, and then they place part of that sample in a solution that contains urease. So if H. pylori is present, the bacteria is going to break down the urease. It's going to produce urease, rather. So it's going to break down urea and trigger NH3 or ammonia production. So this is going to bring up the pH in the solution, which then there's something in the solution that will turn pink if that happens. And that's highly specific for H. pylori. The gold standard test during a biopsy is to take a sample of that tissue, and then they put a stain on it to help highlight and then look for bacteria that are curved and rod-shaped like H. pylori are. So that's the gold standard. However, it is time-consuming because you need a pathologist that's going to get in there and look around on those slides under a microscope. Now, there are other less invasive methods for checking for H. pylori. One is a stool antigen test, and they can use this to get an initial diagnosis and or determine whether or not H. pylori has been eradicated, so to tell us if our treatments have been effective. There's also a urea breath test. So the patient will ingest a urea tablet, and then if the bacteria is present, it will release urease, which then breaks the urea down into CO2. So what'll happen is you'll see a higher amount of CO2 exhaled than what you typically would with someone without H. pylori. So that increased expulsion of the CO2 is suggestive of H. pylori. And they'll also use this one to obtain an initial diagnosis and or determine whether the H. pylori has been eradicated after treatment. And then lastly, they can run some serology antibodies, so they can check for IgG antibodies that act against H. pylori in the blood. However, these are less specific tests compared to the other tests, because there could be other things that, other reasons why someone would detect, or IgG antibodies rather, would be detected. So the other issue is that someone with H. pylori can have antibodies that are detected for years after infection, so it's really not helpful in determining whether this person has a current active infection or whether they were infected previously. So with gastritis, essentially the treatment goal is to reduce the amount of stomach acid to allow the stomach to have time to heal. And with an acute bout of gastritis, that typically resolves in a few days to a few weeks with treatment. However, sometimes it can become chronic if there's recurrent or there's long-term inflammation. And it's not uncommon for chronic gastritis to last for months or even years if it went untreated for a while. And that, of course, puts the patient at risk for developing other complications like ulcers and GI bleeds. So when we get down to the medications, typically what we're doing is we're giving acid suppression drugs and also cytoprotection medications. So for acid suppression, the drug classification of choice is our PPIs, or our proton pump inhibitors, which decrease hydrochloric acid secretion and decrease mucosal irritation. And those are available either over the counter or by prescription. So omeprazole is a common one that's over the counter. Pantoprazole or Protonix is what you'll usually see administered IV or PO in the hospital. So back to your ANP, the parietal cells contain that proton pump, that hydrogen, potassium, ATPase enzyme proton pump that PPIs block. And that enzyme is like the final barrier, or the final step rather, for acid secretion to occur into the stomach. In order for that to happen, and prior to the PPIs getting absorbed by the small bowel, to get to the circulation, to do all of that, it actually needs to go through, a process. And some people have enzymes in their bodies that degrade the PPIs more so than others. And so PPIs may work better for some individuals than for others. So, for example, people with Asian ethnicity tend to have PPIs tend to become more bioavailable to them, and so they might need lower doses. And also with the elderly, PPI bioavailability actually increases. So with elderly, smaller doses are likely required, and so we might have to adjust the dosage for our elderly population. And it could take a few days for these medications to reach their full effect. A couple important things to note with PPIs is that these are best administered before food intake, because when we eat, the proton pump is activated during meals. So if we give the PPIs prior to food intake, it will make the drug more effective. So usually you'll notice on a patient's MAR that PPIs are scheduled first thing in the morning at like 7 a.m. So some patients take them twice a day, and typically it's ordered, first thing in the morning and then maybe 30 minutes before dinner. Now, the downside of taking PPIs is, if you think about it, the acidity of the stomach is protective in nature. So when we take PPIs and the stomach becomes less acidic, there's an increased correlation with PPI use long-term and C. diff infections, also with foodborne illnesses, and with community-acquired pneumonia as well, which they hypothesize is because of bacterial overgrowth. So in addition to your PPIs, another option for acid suppression is our H2 receptor antagonists like famotidine or ranitidine. And again, these are available over the counter and by prescription. Okay, so I just uploaded the slide there to reflect that H2 receptor antagonists, or H2RAs, are another option in the treatment of gastritis. And they work by decreasing hydrochloric acid secretion and decreasing irritation of the esophagus and the gastric mucosa. Now, these drugs might kick in faster, but overall PPIs work better and they last longer. So typically what you'll see are the PPIs being used. But sometimes patients, if their symptoms are worse at night from their gastritis, there is some research to show that H2RAs might help better with acid production at night and help to decrease that acid production at night. The other medication that you see up there is cytoprotection. So cytoprotection is really any agent that works to help coat and protect any ulcerated tissue, or should an ulcer form. So they're going to help stimulate mucus production along the lining of the GI tract. So these don't work not so much by reducing gastric acid, because they do decrease the acid somewhat, but really its main function is to increase mucosal protection. So the sucralfate should be taken on an empty stomach, and that's because the food can block the sucralfate from binding to the lining of your intestine. So if you have food in your digestive tract, the sucralfate can't stick to an ulcer or an area of irritation. It can't stick to the lining if you have food in your digestive tract. So the idea is to take it on an empty stomach to create a barrier to things like pepsin and bile. So if it's being taken to treat ulcers, then you might see patients taking this up to 4 times a day. Maybe if they're doing it prophylactically, or you want to keep an ulcer from returning after it's healed, they might decrease that to 2 times a day. And so for sucralfate, it's best to take empty stomach, either 2 hours after a meal or 1 hour before meals. And if you look at the name, you can see sucra. Sucralfate is a combination of aluminum hydroxide and a sucrose octasulfate. So it can actually cause an increase in blood sugar, so that's something diabetics need to be aware of. And then the other drug, the misoprostol, you may have learned about that in your OB lecture, actually. The trade name for that one is called Cytotec. And this one works by, it's a synthetic prostaglandin analog, and it works by inhibiting basal and nocturnal gastric acid secretion. Okay, so it affects the prostaglandin receptors on the parietal cells in the stomach. So, yes, this is the same drug that can be given to expel a pregnancy, as it causes the uterus to contract. So, do not administer this medication if someone is pregnant, and generally it's avoided with women of childbearing years or in childbearing years. Sometimes it's given to people that are, say, taking NSAIDs who are at high risk for developing ulcers to prevent that from happening. So it helps to induce mucus and bicarbonate secretion. And then also to kind of thicken the mucosal layer for some extra protection. Other treatments, again, as I mentioned before, if someone's diagnosed with H. pylori, you want to make sure that it's fully treated and eradicated so that it doesn't come back and rear its ugly head. If patients are nauseous, vomiting, we can administer antiemetics. In some cases, may have an NG tube placed. Patients will start out NPO, and we advance their diet as tolerated, starting with a clear liquid diet, and then thinking about more bland foods. So in terms of dietary changes, smaller, more frequent meals is better. Avoid eating before bed, avoid processed foods, and limit alcohol and spicy foods and caffeine. We want to monitor volume status, make sure the patient's not dehydrated or hypovolemic. And then you also want to assess for GI bleed, so looking at, vital signs, lab trends, and so on. And as I mentioned, if this is someone with chronic gastritis, they're going to need that B12 supplementation for life. So just going through some of those things, it's pretty clear what the complications of gastritis might be. So that prolonged exposure to that gastric acid can damage the stomach lining, and that can lead to ulcerations in the digestive tract. And if that ulcer, breaks through the stomach wall, then you've got bacteria getting into the abdomen, into the peritoneum, and that can cause sepsis. That chronic gastritis, we were talking about long-standing H. pylori infection, or whether it be an autoimmune disorder. Again, that can lead to atrophy of the mucosal layer, and decrease function of the gastric glands. And again, that can lead to iron deficiency anemia, pernicious anemia, and also increase the risk of gastric cancer. So the more that area is exposed, then those cells start to change, right? So with regard to gastritis, patient education, we want to teach about the dietary modifications I just mentioned. Make sure that they are adhering to their medication regimen, whether that be antibiotics for to treat the H. pylori, or if we're talking about acid suppression, or medications to protect the cells inside the stomach. Make sure that they're taking those medications to suppress the acid and protect the cells on an empty stomach, because they work better that way. Avoid alcohol, and if there's a history of abuse, providing community resources. I mentioned smoking can be a risk factor, so smoking cessation. Teaching patients how to identify and to notify their healthcare provider, or to seek emergency care for a GI bleed. And then also perhaps teaching B12 injections if patients are going to be on that lifelong regimen for chronic gastritis. And that's all she wrote for this one, folks.